All right, thanks for sticking around here to this last set of lectures. Have no disclosures. Again, my topic's going to be primarily on ERAS protocols for cesarean delivery, starting with just the general concept of enhanced recovery and what things we might be able to apply to cesarean delivery. I'll just start off by telling you we don't have many studies at all in using ERAS for cesarean delivery. It's a rather new concept to obstetrics, but we'll go through what evidence we do have. And I'm going to talk probably quite a bit about pain management in addition to the other elements of ERAS. Okay. So to start with, I kind of want a show of hands. Who has any sort of ERAS protocol at their institution? All right, so that's probably about 2/3 of the audience. And of those people who raise their hands, raise them again if it's a colorectal surgery ERAS. Okay, it's almost the same number. And I would say that's where we have most of our experience to this point is really in colorectal. For those of you that don't have an enhanced recovery after surgery protocol, the general concept is trying to come up with sort of a pathway for the patient from the pre-operative, even pre-procedure while they're thinking about the surgery, trying to optimize their condition, getting everything ready for surgery, optimizing intraoperative aspects as well as postoperative care, trying to enhance their recovery, decrease their stress, have them be able to leave the hospital earlier but in better condition. It's a very proactive, patient-centered approach. The patient has a significant role in all of these pathways. They're incredibly multidisciplinary and complex, and this is just sort of an example of sort of a flow diagram of things you might think about, and you can see a whole variety of options up there, from hydration to exercise ahead of time to hemoglobin optimization to getting lines and drains out early ambulation, multimodal pain therapy, and so on. Okay. Again, most of the experience we have to date is in colorectal, so I have just a diagram up here of a sort of typical colorectal enhanced recovery after surgery. You can see in the preoperative area, early counseling, getting some nutrition and fluids ahead of time within the guidelines, 2 hours for clear liquids, but getting some carbohydrates in there. In colorectal, decreasing bowel preparation, appropriate antibiotics, intraoperatively, epidurals, better pain control, avoiding fluid overload, and then postoperatively, as we said, early mobilization, getting drains out, things that can be done to improve gut motility, which often keep patients in-house. ERAS has grown so much since its beginnings in the 1990s that just a few years ago, there was an ERAS society developed where they have yearly meetings and they go over guidelines and protocols for a variety of surgeries. They have a website. You can go look up guidelines for all sorts of surgical procedures. And this is a 2017 JAMA article which talks about their society. You can see the procedures that currently exist. What you also should notice is none of that list contains cesarean delivery. Okay, so we didn't even make the part where it says under production, right? So again, a lot of what I'm saying is not going to be based on a tremendous amount of data as far as ERAS goes, but I'll try to share with you the data we have regarding the various elements of a pathway for cesarean delivery. Okay, so again, why would you want to do it? Well, within colorectal, we do have a significant amount of data to date, and this is a systematic review of the literature and meta-analysis, and you can see that for colorectal, we have a decrease in the length of stay when an ERAS protocol is put in place. Most of these are before and after studies. Okay. Other things they noticed within colorectal surgery, besides the decreased length of stay, decreased overall morbidity, decrease in non-surgical complications. That means cardiac complications, respiratory complications, urinary tract infections. And despite getting the patients out a little over 2 days earlier when ERAS protocols were put in place, they had similar readmission rates, which is really important to follow to make sure if you are able to get people out earlier, it doesn't just mean they're coming back more, right? And surgical complication rates were similar whether or not the patients had been in a protocol. Other examples we have, spine surgery. So this study on spine surgery, again, a before and after study, before and after implementation of a protocol. And what they focused on in this particular study was multimodal analgesia. So during the intraoperative spine surgery, using some ketamine, some gabapentin, having good postoperative pain control regimens, early ambulation. What they found was they were able to decrease the overall opioid consumption, decrease length of PACU stay, a little bit less nausea and sedation. Gyne surgery, similar idea, better post-op pain control, use of epidurals, early ambulation, and what they noticed was a decreased post-op opioid use in the first 2 days after gyne surgery. It was huge. It was an 80% reduction in this study of around 200 patients. They decreased the hospital stay by 4 days. They got better bowel return and no difference in overall complications. A little bit of a decrease in cost also, which the hospital always likes to see. So just the idea that trying to protocolize things and get people on a pathway and optimizing as much as we can could have significant benefit. Now, what about cesarean delivery? What would we want to think about? So this was an editorial that was written about 4 years ago saying, should we do this in cesarean delivery, apply these other ERAS protocols and general concepts? And you can see in the circles general ideas about getting patient education materials to them earlier in the antepartum period, trying to optimize their health, getting some information on breastfeeding and other education about postoperative care that they should be undergoing. On the day of delivery, trying to get a little bit better nutrition to them, more appropriate use of multimodal pain analgesia, getting them ambulating earlier, getting Foleys out earlier, getting them better support to try to get them through this process with better pain control, better satisfaction, and potentially a decreased length of hospital stay. All right. What evidence do we have currently within cesarean delivery and ERAS? So this is a study out of the UK, and it's about 2 years, a year and a half old now, and it shows you the progression from 2011 to 2014. This hospital has about 750 deliveries a year, and they were smart and got sort of background data on a lot of aspects prior to implementing the protocol. And I will reiterate how important that is. If you want to show a difference by implementing something, if you want to show your added value to the hospital administration, it's important to have that data before you implement your protocol. So that's what they did. And you can just see there where they had the first meeting, the patient information, implementation of additional nutrition and patient warming in there. Now, the UK is a little different. Their endpoint was the percent of patients they could get out on postoperative day 1 after cesarean delivery, right? Which is pretty much unheard of in the US. Now, in the UK, they have a very different home healthcare system. They have much better and closer follow-up after someone is discharged from the hospital, and so it was something that they could implement in that situation. And they've shown here quite well that with implementing this ERAS protocol, that they were able to get patients ready to go home successfully with no difference in readmission rates with implementation of their protocol. Okay. Now in the US it's different, right? We have legislation that if a mother wishes to stay up to 4 days following a cesarean delivery, she has every right to do that. So the focus of our protocol that I'm going to talk about, and I think others that are out there, is really optimizing factors to get the patient ready to go should she choose to go home on post-op day 3 or even post-operative day 2. Right? Other things we're really focusing on are maternal satisfaction, on appropriate pain control, decreased opioid use. So it's not just all on length of stay. And then ultimately, too, is there a cost benefit? Okay. So before I go any further, I have to give credit to a colleague of mine, Dr. Harbell, who really spearheaded the effort with me on OB, getting our ERAS protocol in place. I don't expect you to read that at all. We're going to go through various parts in the slides that are coming up. But the concept you should have is the different colors are the different parts of the pathway, from the antepartum clinic area to the pre-op, to the intra-op, to days postpartum after cesarean delivery. The columns are the different specialties, from anesthesia to the obstetricians to nursing to the patient themselves, and also the neonatologists are involved. And so really this multidisciplinary approach to improving the patient care experience. Okay. So when you implement one of these giant protocols, there's many ways to do it. And I've been in contact with colleagues around the country. One here, Eric Hunt, who works in the Kaiser group here in Northern California. And people implement these all different ways. At UCSF, we chose to implement it on just a subset of patients first, which was the elective cesarean deliveries, because it was something we felt we could control easily. We knew when they were coming. It was easy to get all the pieces together for the protocol. We have since expanded to all cesarean deliveries as planned. At Kaiser, at their hospitals, they rolled out to all the cesareans at once. And I think there's pros and cons. The one issue that we had by only doing a subset is people would confuse the protocol for almost like a fast-track protocol like you would have in cardiac surgery. Like we were doing something different to these patients because they were, quote, so healthy and had an elective C-section, when what we were trying to do was just implement standard evidence-based medicine for cesarean delivery. And then we ended up with 2 order sets, one for the ERAS protocol, one for the standard, and that added some headaches to it. So you can see the potential benefit of rolling it out to everyone. The flip side to that is if you roll it out to everyone, you always have exceptions, right? You have people who had epidurals who labored first, people who had elective cesarean sections, people with preeclampsia or other comorbidities that you might want to change some of the different medical management for. I do think there is a benefit to, when you roll it out, having a standardized order set ready for the pre-op, intra-op, and post-op periods. There are so many elements of these protocols that if you don't have your standardized order sets, it's almost impossible to get all the elements correct for each patient. Equally important is having a way to collect the data on how you're doing. The next slide is about outcomes that you might want to measure. The issue is that if you're not collecting your outcomes, you don't know how to tweak your protocol. This is really an iterative process where you're going to implement an order set based on the evidence. Some things are going to work at your hospital, some things are not going to work that well, and you're probably going to have to change things once or twice at least to get something that's going to flow well for your specific location. If you're not collecting data, it's hard to know what's working and what's not. Okay. These are examples of outcome measures. They got a little smaller since I made the original slide, but I think you can still read them. We spent a lot of time tracking opioid use before and after our ERAS protocol. How much oral morphine equivalents are patients using in the PACU in the first 24 hours, in the first 48 hours. We're actually doing phone calls a week out. How many pills did you take? In addition, we're following up a month out with satisfaction and pain scores also. One of the questions that came up is, as you know, there's sort of a national effort to appropriately reduce opioid use through multimodal pain therapy. And there have been some studies that show that if you, the more opioid that's prescribed that the patient takes home, the higher the correlation of them becoming dependent on opioids. So only through 7-day, 30-day follow-up can you get an idea of how much opioids patients should be discharged with that's appropriate. You don't want the obstetricians to have a lot of calls from the patients asking for refills, but on the other hand, you don't want each patient to end up with 20 or 30 extra opioid pills at home just sitting in their medicine cabinet. Length of stay data, obviously, pain data, complications and side effects, cost. I think equally important with cesarean delivery that's different than the other ERAS protocols is taking the newborn into account. I think it's very important, since we don't have much data, to look at readmission rates of the newborn. If you are able to get the mothers to go home, say, a day earlier, they may have great satisfaction. But if, on the other hand, you find a higher readmission rate of the newborns because the appropriate screenings weren't getting done, that wouldn't be good. So you need to follow that. Similarly, you might want to make sure that you're not impacting appropriate breastfeeding. Okay. I think the biggest thing to follow that people might forget is compliance with the protocol. So you have to have a way to know what % of your patients are actually going through the majority of the protocol. So that if you see things aren't getting better, you need to know whether it's an element of the protocol or whether it's just not being followed. Within the antepartum period, we've distributed a lot of education materials trying to get appropriate expectations and education on why we have the protocol, for example, why we do multimodal pain therapy, why we encourage the mother to take round-the-clock Tylenol and ibuprofen, in addition to the opioids on top, rather than doing opioids first. We like the patient to enroll in our electronic medical healthcare system so that they can get the education materials. We found when we looked at instituting this, there were little barriers to patients being discharged on time that I was completely unaware of. We wouldn't let people go unless they had a car seat. So unless they were educated to buy the car seat prior to coming to the hospital, that was a barrier. And they would often have discharge delayed, up to 12 hours while a family member went and bought a car seat. For us, they had to have a first visit scheduled with a pediatrician, right? Prior to coming to the hospital, we also provide them with a standard antibacterial scrub and a nutritional clear liquid that we encourage them to drink on their ride to the hospital so that we stay within clear liquid guidelines, but they've gotten some hydration and nutrition sort of in the immediate time prior to the surgery. Once they get there, we make sure they've had their clear liquid. We see what elements of the protocol have been followed. We, of course, review their H&P. We spend some time with incentive spirometry education. We go over that with them to minimize respiratory complications. We actually give them a preoperative dose of acetaminophen, standard antacid protocols that the ASA OB guidelines use. And then we like to standardize our pre-op fluids. Before I did this, I didn't realize that our scheduled C-sections were just getting a liter of fluid at some point pre-op, even if it was going to be hours before the surgery. So we standardized that to a much smaller amount on an hourly basis, and we happen to use a co-load when we do a spinal. But at any rate, that was something that came up when we were looking at this. Again, this is an example of how we look at compliance with our ERAS protocol. Not only do we have a standard surgical checklist that you all do, is the consent signed, is the NPO status appropriate, allergies and so on, but we added additional checks on if they have their clear liquid nutritional beverage, as well as did they get their incentive spirometry education, so that can be documented. Okay. So let's talk about just a couple of elements I mentioned. You've already had lectures these past couple of days on having some nutrition prior to surgery, and NPO guidelines, but this was a Cochrane review out of 2014. It's not just for cesarean delivery, it's abdominal surgeries in general, and they did see a little bit of benefit by giving some preoperative nutrition. Didn't see any increase in side effects by doing that, obviously staying within the 2-hour clear liquid guideline. This was a study out of Toronto. This is in term pregnant women who were within the guideline of fasting solids within 6 hours and clears within 2 hours, and they used ultrasound to look at stomach contents. And you can see that about half of the 100 had nothing in their stomach. The other half, with the exception of one, had just baseline residual amounts that are very standard before an operation, and there was only one that had sort of a higher baseline fluid level. At UCSF, our other ERAS protocols, for example, our colorectal, our mastectomy ERAS protocols, happen to use a clear liquid that has about 250 carbohydrate calories in it, and in addition has 9 grams of protein. It is clear, it is a clear liquid, but there has been concern in some of the literature about protein slowing down the gastric emptying time. We use it, and I have down there a 2015 study where they looked in pregnancy at term milk, orange juice, fluids, regular clears, and really noticed that the gastric motility was due more to the overall calories and the volume, not so much the individual components. So for whatever it's worth, we happen to use protein in our clear liquid, but others do not. They just use a pure carbohydrate. The other benefit of the protein there is a little more reliable glucose levels, and the protein's also been shown to have more normal peristalsis with the gut motility. Intra-op, we're going to talk in the next few slides on neuroaxial opioids. You've already had lectures on vasopressor use and antiemetics. We really focused on also the experience and the satisfaction, so making sure there was appropriate accommodation for a partner in the OR. We actually allow up to 2 people in the OR to support the patient if that's what they want. Early skin to skin. We happen to use transparent drapes. They're not initially transparent, but right after birth, the opaque portion can be lowered so the mother can see the cesarean delivery and then the opaque portion placed back. So I'm going to stop there on the ERAS and talk just a little bit about cesarean delivery analgesia. So I'm going to go back in time to the late 90s, early 2000s, and this is some studies by Palmer looking at various doses of intrathecal morphine. And you can see there on the analgesia graph doses from nothing up to 500 mics. And you see sort of this curve where right around 100 mics, it sort of levels out with the exception of the 200 mics, which has an incredible variability to it. So much so that I've seen textbooks that use this graph that take out the data at the 200 microgram level because of that variability. It turns out, I'm going to take a wild guess that many of you, especially if I go back 10 years, were probably using 200, 300 mics, somewhere in that range for your intrathecal morphine, sort of with this data. And we also see a fairly linear increase in itching the farther you go up on the intrathecal morphine. Nausea and vomiting was quite variable, but very, very minimal respiratory depression actually across all the doses. Well, let's move forward in time to 2013. Here we have a study comparing 100 mics of intrathecal morphine and 200 micrograms of intrathecal morphine. We do see, if we look at opioid use as a measure of its analgesic efficacy, that a little bit more opioids were needed with the 100 mics compared to the 200 mics. We see that pain scores are very good in both of them, but statistically lower at 1.6 compared to 2 at 24 hours with the higher dose of 200 mics. The other thing we see is more side effects with the 200 mics, right? In this study, all the patients got preemptive Zofran or ondansetron prior to the Caesarean section, and this was additional antiemetic use. It's almost double in the higher dose of morphine, and a statistically increase in the nausea episodes. So it's sort of this trade-off between pain and nausea as a side effect. And when you ask patients how they would rate their preference, sort of where they would put their money to get rid of a certain outcome or side effect, although pain is the number one that people would like to not experience, nausea and vomiting are right below it. So it's not an obvious question that it's just pain. The side effects are very significant also. Okay. Well, now we have a new study in 2016 from Columbia comparing 50, 100, and 150 mics of Duromorph intrathecally. And in this study, which is different, actually I should go back, I apologize. This study used round-the-clock NSAIDs, which is why I think they got better data than that older data regarding intrathecal morphine. This new study from Columbia uses round-the-clock NSAIDs. They do Toradol dosing with theirs of 15 milligrams Q6 hours in all the patients. They noticed no difference in the pain scores for the first 24 hours, regardless of which allocation the patient was randomized to for the intrathecal morphine. They saw no difference in PCA morphine use, which is what they used for the study. So no difference in pain scores or postoperative morphine use between the three. And they did notice a little bit less itching at 6 hours in the 50 microgram group. They didn't see any difference in the nausea and vomiting. I've reread this 3 times because that 6-hour one really looks like it's lower in the 50 mic group for nausea and vomiting. It turns out those are confidence intervals. They're not standard deviations. They're the 95% confidence intervals, and so there really wasn't quite a difference, but it looks like they were getting close. So I would say, that with appropriate multimodal analgesia, we probably could go lower. I certainly feel confident saying we can do 100 micrograms, and based on that one study out of Columbia, maybe 50 is also adequate. This is epidural morphine because obviously not all your C-sections are with spinals. Some are following labor with an epidural. And we see here that the analgesia sort of after 3 is about the same, and the itching goes up also with the dose. And this is the old data before multimodal pain analgesia. Here we have a more recent study, 2013. Here they're getting both round-the-clock acetaminophen and round-the-clock NSAIDs. They've reduced the dose of epidural morphine to 1.5 milligrams and 3 milligrams. They see no difference in the pain at rest, no difference in the pain with movement, speaking to the idea that you could probably reduce your epidural morphine for post-op pain to about 1.5 milligrams, right? Itching was higher in the 3 milligram group in the first 12 hours, and a little bit increase in nausea and vomiting too. So more side effects with the larger amount of epidural morphine. Okay, so besides optimizing your neuroaxial morphine, what other things would we think about for post-op? Well, early mobilization, and that's really only going to happen if you have Foley removal fairly early. We have a protocol written to try to get the Foley out within 12 hours. If the patient's had a long labor or the obstetrician is concerned, they can rescind that order and extend it for as long as they want, but the default is 12 hours. I'm not going to talk about DVT prophylaxis because that's your next lecture coming up. Multimodal pain control is the next couple of slides, having round-the-clock NSAIDs and acetaminophen. We happen to do Toradol, 30 milligrams Q8 hours for the first 24 hours, and then we switch over to ibuprofen, 600 Q6. Acetaminophen, we give 1 gram every 8 hours round the clock. Having a good bowel regimen, incentive spirometry, and advancing the diet as tolerated, but aiming for regular on postoperative day 0. You've already had a lecture on the effects of pain and depression, but just to sort of reiterate the importance of this good pain control, this study by Eisenach in 2008 showing kind of poor pain control after both cesarean and vaginal deliveries, and this impact of poor pain control on a variety of activities like walking, mood, sleep, which are very important when you're caring for a newborn. Most surprisingly was the correlation with severe pain and an increase in depression. So much so that women who had severe pain sometime in the postpartum period, defined as a score of 7 or greater, had a 2.5-fold increase in persistent pain and a 3-fold increase in postpartum depression. Right. Now the good news is, by the time they looked a year out in another study, those increases had gone away, but in the short term, there's a huge impact from poor pain control. Just really quickly, who uses round-the-clock NSAIDs for postoperative cesarean delivery pain relief? Okay, so we've got probably 2/3. How about round-the-clock acetaminophen? Nice. So we've got over half. You can see the data there from 2009, where round-the-clock was just under half for NSAIDs, and only about under half were using round-the-clock acetaminophen. We have pretty good data that if we do round-the-clock fixed interval NSAID dosing, here in this study they were doing it Q6 hours compared to not having it. They were getting much better pain control scores by having the fixed NSAID regimen following cesarean delivery. This study out of Stanford in 2015 comparing scheduled acetaminophen with the opioids PRN versus the PRN combined preparations of oral acetaminophen with opioids. It was a retrospective before and after chart review. They were using 200 mics of morphine, and they were using round-the-clock ketorolac and ibuprofen in everybody. Okay, what did they find out? Less opioid use in the round-the-clock acetaminophen group, and interestingly, also less acetaminophen use in the scheduled acetaminophen group, as opposed to having it connected to your oral opioids. I think most importantly, when I looked at this study, I saw that in the group that got the scheduled acetaminophen, they also had the scheduled NSAIDs, right? There was a significant percentage, about 28%, that didn't even need opioids other than the intrathecal dose. And even though I don't have data to show you from our ERAS protocol because it's not peer-reviewed yet, we have experienced this where more and more I'm seeing a handful of patients go through post-cesarean delivery with our 100 mics of Duramorph and not needing any more opioid after the cesarean delivery. Now they're in the minority, but we never had that before. Okay? So the last items to this are other things to think about: good consultation with lactation nurse, preparation for circumcision so that doesn't delay the discharge if that's something they want, flu shots, car seats, birth certificates, appropriate follow-up appointments. We had to really work on discharge meds, getting our patients appropriately discharged medications on time so they weren't prevented from going home. And then the other idea finally on this slide is just that it's an iterative process. Ideally, you'll put in your protocol, but you really need to follow up on your outcomes, see what's working and what's not, and keep tweaking it as you go to optimize it for your specific location. Thank you.